Shall I start? I can't see Dr. Fazil. Yeah. Hello and good morning, everybody. To commemorate the World Stroke Day observed on October 29th every year, we bring you today's webinar on management of stroke, continuity of care. As part of the Hindu Wellness series, the webinar is presented by Kauvery Hospital. In simple terms, what heart attack is to your heart, strokes are to your brain. A stroke is the brain's equivalent of a heart attack, which means it happens when there is an issue with blood flow to some part of the brain. And this interruption in blood flow could happen due to blocked blood vessels or due to bleeding in the brain when a blood vessel ruptures or atrophies. Strokes can be life-threatening emergencies where every second counts. Immediate medical attention is critical to prevent permanent damage or death and helps in quicker recovery without any disability. The time between suffering a stroke and the treatment is of utmost importance, and doctors say there are two golden hour periods for strokes. The goal for management of patients with stroke is to stabilize the patient within the first 4.5 hours when medicines may help, or within 24 hours, which may require other small procedures or other interventions and a complete evaluation. Today, we have three doctors from the Kauvery group of hospitals for the discussion on how to recognize symptoms of a stroke and what should be done, the various treatment modalities, rehabilitation, and physiotherapy. Once they are done with their presentations, the audience is invited to send in their questions addressed to the three doctors. So let me first introduce our panelist, Dr. S. Kauvery, consultant neuroanesthesia and neurocritical care in Tirunelveli, an MBBS degree holder from Tirunal Medical College, an MD and DNB in anesthesia from All India Institute of Medical Sciences, Delhi. Dr. Kauvery's field of interest is acute trauma care and emergency neurological services. And now she will talk about the system of care in stroke management. A very warm welcome to you, Dr. Kauvery.
Thank you, ma'am. So let me start with my presentation. So our main aim is here to make you understand what stroke is so that you are not scared to get the optimal treatment to get back to your normal life. Whether my screen is visible now?
Yes.
Yeah. So what does it actually mean, systems of care? So it starts right from the society till the patient is back to normal life. So here we are going to see how the patient is received in the ER and how the patient is discharged and what we do actually. So as a neuroanesthetist and intensivist, our care starts right from the ER since the patient is received. We have to optimize the patient to make the treatment available at the right time, to get organized care, to support his organ system through this time, to pave way for the recovery and the post-discharge care. So let me get you through some scenarios. See, here is a 39-year-old male who had no illness previously. He woke up normally, he brushed up his teeth, lost his balance while drinking his morning cup of tea. His coffee cup fell down and he fell down. Relatives noted there is some asymmetry in his face and he is not able to speak up, though he is aware of his surrounding. So here comes our signs and symptoms. Be fast. This is the acronym. So what is this be fast notes? So when someone lost his balance while walking, or when he could see something different, double vision, or when you could find some difference in his face, when he has his weakness over his arms, when he's not able to speak clearly. So this the time to alert. We all know when the heart stops. Most of the people are now aware that doing some chest compression will make his life regain. In the same way, if you get the treatment at the right time, the patient can recover his life back without any disability. So this is the another scenario. See, 55-year-old male taking medicines for sugar and BP. He was watching his TV in the evening, suddenly noticed the things are appearing as double. He was feeling dizzy when he tried to get up and he lost his balance while he tried to walk. He may think this is because of his low sugar, or he may think he was feeling just quite not okay because of his illnesses. But this is the time he should understood that something may happen in a critical state, and this is the time that he should approach the medical care. Here he falls under B and E. And this is the another scenario. 62-year-old diabetic man, he was found unconscious, lying by his bed by his son in the morning. So we don't know actually when the stroke happens, maybe early in the morning or way to night. The advanced imaging will help. So now the patient is on the way to hospital, either through his own vehicle or through the ambulance. Now the hospital system has to be notified. The attenders may call up the hospital where this facility is available rather than wasting time to going to the nearby nursing home. So our target stroke time starts now. So why we are very stressed upon this time? Because every minute around 1.9 million brain cells die. So here you can see within some 10 minutes of stroke onset, these cells die up. And within 1 hour, this volume increases. 3 hours, this volume increases. 6 hours, the most of the cells die up. Though this may vary with the persons depending upon the other blood circulation scenarios. So this is the time where you should get the optimal treatment to make these dying cells live again. So emergency response, the paramedic can give us the clue that the patient is arriving. So we are right at the ER to receive the patient. Here we have to decide whether the patient has to go straight to the ER or to the CT room. So we can assess whether the patient needs optimization, whether we have to get the BP treated, whether we have to give his oxygen, or if the patient is well good enough to go to the CT room, the ER room can be bypassed and the patient can be taken straight away to the CT room. Here the team is alerted, everyone is at the CT room. Here we have a team of admin who initiates the call and the ER physician who receives the patient, the intensivist who optimizes the patient, the nurses here to make everything set for the patient to get the CT done, blood to draw to the lab, and a neurologist, neurointervention specialist, and the neurointensivist. Now the patient is taken straight away to the CT room. Here the patient is on the CT room. We are ready to get the imaging done. In the meantime, we will follow with the lab to get our lab result, though we don't need every blood result to be out to give the medication. So the CT brain is out. We could find there is no bleeding in the brain. So it's not hemorrhagic stroke. It's mainly due to some clot in the brain. So the attenders counseled, patient counseled. It was discussed in detail about the drug available, clot busters available, what has to be done, how is the treatment course, what could be the post-drug event, everything. So just we are relaxed as the drug is in with the right time. So what we here stress is door to needle time, so that now every second is utilized once the patient reaches the medical care, and at the right time the drug is in. So in the CT console, we can even inject the drug if the hospital is optimized for that. Once the drug is in, we can proceed to the next advanced imaging like the angio through the CT, so that we look at the blood vessels. We could find how his blood vessels are. If you could note some clot in the blood vessels like this is the cell already died, and here we have the cell to be perfused again. So the attenders are discussed. If there is no clot in the blood vessels, then the patient will be taken to the ICU for post-thrombolysis care. We have to look out how his symptoms are resolving, how he is able to maintain his own organs, and we have to look for the complications also. If the patient had sudden worsening or complaints of headache, then the patient will be taken back to the CT thinking that he may bleed in the brain. So if everything goes on well, then he will move next to the phase of rehabilitation. So if we found something blocking his major blood vessel, then he will be directed to the cath lab shoot straight from the CT without going to ICU, so that we don't waste any time there. So here he may need some kind of sleeping medication or a full anesthesia depending upon the patient's system. So the other main concern here is secondary injury. The brain is already traumatized by stroke. So we don't want the brain again to get insulted with any kind of this, like low oxygen, high BP, low BP, or variations in blood sugar. And the thing here needed is continuous monitoring of neurology so that we know every event happening with the patient. So when we receive the patient ahead of time, more than 20 or 24 hours, or if our treatment fails, the patient is worsening, the patient is not aware of surroundings, then the time is gone, cells are lost. Now our main aim is to save life. So what we do is we will give some kind of drugs to reduce his swelling. We will do critical care support. What? In the time he needs some amount of tube in the nose to give his feed, tube in the windpipe to ventilate him, to give him oxygen, to give him breathing, tube in the bladder to take his urine, and the extensive nursing support to make him survive through this phase so that he will move next on to his rehab phase and near back to his normal life. So if the medical treatment fails, see here the dead cells and there is swelling around the brain. So this is not only endangering his neurology, but also causing compression over the normal brain, which may endanger his life. In this scenario, we may need to take his some amount of bone there so that the swelling goes on that side and there is no pressure over the normal brain. The immediate danger to life has been removed and the patient need extensive critical care support. As we all know, brain is time. The brain also takes time to recover. So in this critical phase, patient needs time. The cells need time to recover, to go back to its original state. The attenders need to be patient. We have to encounter all the problems in the ICU, but with proper supportive care, the brain takes its own time to get back to its normal status with the help of extensive physio rehabilitation, which I will further elaborate now. So the final message, time is brain. Get the symptoms recognized at the right time, get into the hospital, get treated at the right time, and get back to your life without any disability so that you are back to your own life. Thank you.
Thank you, Dr. Kavu, for that very nice presentation and explaining things so beautifully. Our next panelist is Dr. S. Fazil, consultant neurologist and clinical lead in stroke and neurointervention at Kauvery Hospital, Trichy. He has a DM in neurology from Madras Medical College and has completed postdoctoral fellowship in stroke and neurointervention from Rajagiri Hospital, Cochin. He is also an European diploma in stroke intervention. His presentation today is on recent developments in intervention and stroke management. So over to you, Dr. Fazil.
Thank you very much. A very good morning to everybody. So I'll start sharing my screen. Yeah. So this is part of the awareness because of tomorrow is World Stroke Day. So I'll be speaking about a few things. It will be overlapping with Dr. Kavu's presentation. So start the presentation. Yeah. So stroke is nothing but a brain attack. As if there is a blood vessel blocked in the heart, it is called a heart attack. So if any block is there in the brain, it is called a brain attack. In the same time, there is another type of stroke where suddenly your BP shoots up. There is a rupture of the artery in the brain, which causes hemorrhage or bleeding in the brain. So grossly, we divide stroke into two types. One is because of the clot and one which occurs due to bleeding in the brain. We wanted to simplify stroke so that we have coined the term brain attack so that everybody understands. And this
Excuse
is the
me, doctor, are you sharing a screen because it's not visible?
Yeah, I'm sorry, one second. Is it
Yes,
visible
we
now?
can see it now. Yes, yes.
Yeah, yeah. Yeah. So I was saying stroke is nothing but brain attack, which happens due to two reasons. One is because of block in the brain, and one is due to bleeding in the brain. So as Dr. Kavu was mentioning, this is the famous mnemonic which we use to let the know the symptoms of stroke. One is B. B stands for balance. Somebody suddenly become unsteady and not able to walk properly. And E stands for eyes, where suddenly your vision is blurred or you're not able to see properly. And F stands for face, where your face is being deviated or the angle of mouth is deviated to one side. And A stands for arm, where suddenly your arm and legs are becoming weak on one side. And S stands for speech, where you're not able to speak or your speech is slurring. And T stands for time, where we are emphasizing that if at all you're noticing this above symptoms, you have to rush to the hospital. And what are the risk factors for stroke? These are all the usual suspects which even cause a heart attack, like high blood pressure, diabetes, cholesterol, family history, age more than 50 years, previous history of stroke, smoking, alcohol, obesity, physical inactivity. These are all the usual suspects or the risk factors that can cause stroke. And how do we diagnose this stroke? So everybody knows that a chest pain is there, patient is going to the hospital, and ECG is done, and a heart attack is diagnosed. In the same way, as I was mentioning, for me to know if it is a stroke or if it is a clot or a bleed, I have to do at least an MRI or a CT to diagnose a stroke. So stroke is usually diagnosed through doing a scan. So as Dr. Kau was emphasizing, time is brain. So what we do? So once a patient comes to us with the above complaints, we do a scan, diagnose a stroke, and if at all the patient is within 4.5 hours from the stroke onset, we try to give a medicine called tenecteplase or alteplase, which are nothing but clot busters. So when there is a clot in the brain, we are trying to dissolve the clot. So we give a medication within 4.5 hours. And if at all a large vessel in the brain is blocked, then we do something called a mechanical thrombectomy, where we are putting a small puncture through a keyhole in the groin, and we are taking certain tubes and enter the brain exactly where the clot is there. And you can see that the stent retriever is being deployed and the clot is completely taken out, so that the blood flow is completely restored. So if there is a small vessel occlusion, just small a basic medication will suffice. But whereas there is a large vessel occlusion, then we have to do a procedure called mechanical thrombectomy to restore the blood flow. So as I told, the risk factors, can stroke be prevented? Yes, definitely. Keeping your blood pressure low, lowering your cholesterol, eating healthy, exercising regularly, stop smoking, and if at all you're drinking, drink in moderation. Try to avoid stress and anxiety. So this is the ways that stroke can be prevented. Thank you. The message is, be aware of the symptoms of stroke, and time is of utmost importance in stroke.
Thank you, Dr. Fazil, for the nice presentation. Our final speaker is Dr. Venkataraman Karthikeyan, consultant neurologist, neuroimmunology, and Parkinson's disease at the Kauvery Hospital, Main in Chennai. A medical graduate from Kanyakumari Medical College, Dr. Karthikeyan completed his MD in General Medicine from Kilpauk Medical College, DM in Neurology from Madras Medical College, and DNB in Neurology. He's also a clinical fellow in neuroimmunology and advanced therapeutics in Parkinson's disease from NHS Foundation Trust, Liverpool, UK. His areas of specialization include multiple sclerosis, myasthenia, deep brain stimulation, spasticity, cranial blocks for headache, and stroke management. His presentation now is on rehabilitation of stroke patients post-hospitalization. Welcome, Dr. Karthikeyan. You have to unmute yourself.
Yes. Thank you. It's a good presentation from my colleagues previously. They've detailed the management of stroke. As the cricket fever grips on us, let's put it, we've had the T20 version of stroke so far, where it's all fast, going everything, catching up with the patient's life and saving him. I'm going to talk about the test version of stroke management. It's going to be slow, steady, but that's the real cricket, and without which the rehabilitation, without which the care of a stroke patient is absolutely incomplete. So, is my slide visible?
Yes.
Yes. So going straight to the content, we don't have much of data on how the stroke prevalence and incidence is happening because the data collection is not to the mark here. But what we know is that the incidence of strokes is somewhere between 100 and 170 for a lakh people in a year. So that is what we have in India. And taking that number and calculating the strokes based on the severity. The strokes can be mild, moderate, and severe. The mild strokes are very normal, very mild in the symptoms. They'll be having numbness, there'll be some weakness, which would not hamper their day to day activity. So, once they get discharged within a few days to weeks, they are back to normalcy. So, with such mild strokes contribute only to about 2.7 to 18%, which means about 80% of strokes are moderate to severe, which means they become disabled for a longer time. Even in the milder strokes, not every mild stroke becomes symptom free. People who have ataxia, that means imbalance as their stroke symptoms, even though it is milder, even though they have a good strength, they have a lot of disability to get back to their normal life. And we were talking about the magic drug of thrombolysis and the thrombectomy, which are right now the hot topics, and which most people can get used to if they rightly approach the hospital at the golden time. Despite that, the papers or the literature from the Western world claim that 50% of patients who underwent these thrombolysis and thrombectomy are disabled to a level where they cannot get back to their day-to-day activities and occupation, making them dependent on somebody for their daily life. So you take that and we calculate the numbers. So it is about 80 cases of moderate to severe strokes, considering, which is not at all real, considering that even 50% are getting thrombolized. It will be a 60 cases of disability for every 100 cases of stroke that we have. And that will make a number of 5,000 stroke patients will be disabled in a crore of a population. These numbers are very difficult to prove or judge, but even half of this number or even less than that is a considerable number of population who have now gone from walking, jogging, participating in their occupation to bedbound or dependent state, where their quality of life goes considerably down despite being alive. So, if you take a recovery in stroke, there are two types of recovery. One is the neurological recovery, where the neurons themselves are recovering and trying to make connections around, or the damage is recovering faster. And this happens about in the first 3 months, and after which that plateaus. No neurons recover, or very less neurons later. However, that is not equivalent to a patient's functional recovery, which means the patient can still recruit the survived neurons to take over the functions of the neurons that have died, and in turn get back to their normalcy, which we call as the functional recovery. That just goes on till 3 years, although the maximum, the peak of that recovery happens in the first 3 months. So that is where we come with the effective concept of rehabilitation. And a lot of factors determine this: the age, the volume of the stroke. If the stroke is an hemorrhage, it becomes bad. The experience, for example, person is highly functional. Let's presume a guitarist. He uses his limbs very frequently to play a guitar, so his hand area will be much represented. So the area of the hand gets easily connected faster than a person who's keeping his limbs idle. And of course, the comorbids, if the patient is an asthmatic, if he cannot exercise, these things interfere with the outcomes. So when do we start? If the rehab is the medicine post hospitalization, when do we start? every person in a stroke should be started on an aggressive rehab immediately, 24 to 48 hours after the hospitalization. That means while they are still in the ICU or where they are still in the ward, the rehabilitation should start. And there are ways to effectively triage these patients, whether they should be in the bed, whether they can be mobilized out of the bed. And there are multiple ways to do this. And these need not be so technical. It can be as simple as a mouth cleaning by a staff nurse that would prevent aspiration. And if that effectively is thought to the caregivers, a frequent hospitalization or a prolonged hospitalization can be prevented, because we need the patient to get on to the heels and start his rehabilitation or her rehabilitation as soon as possible. And we don't want a fever or another comorbidity to prevent it. So whatever methods that can be done to make the patient free of any other comorbidities immediately into the rehabilitation after the effective medical treatment has been done is something which will make the patient get back to the social life as soon as possible. Now, we have scales to know where the patient can be placed after the hospitalization. Based on the score, they can be outpatients, they can be in specialized rehabilitation wards, or they can also be in dependent wards. And the center where I got trained, we had a level of care where the patients move from an hyperacute care to an acute care, and also a hospital-based rehabilitation ward, and then sent into the community. This happens over 3 to 6 months, and it's not done by just single person. This is the team that gets involved with this. It's a huge team, and a team that works around the patient to put him back to the society and give him the effective measures so that he participates in the way he already does. These are few ways that it is done. The wards are equipped well to hoist the patient and then take him to the restrooms. And there will be a scheduled the activity scheduler which will be marked for, so that the patient doesn't lie simply. He is be given a job to be done every 1 hour, whether it's an occupational therapy, physiotherapy, mental activities, or participating in group therapy. Now, we do it with a lot of scales, but where does a neurologist here, and what does he do at the hyperacute stage where Dr. Fazil and Kau were speaking? The main job of a neurologist is to manage the patient with aggressive medical care, and then he will take the decision on triaging the patient for mobilization. And once the ICU stay, if we feels is done, immediate transfer to stroke ward, and then do all the enough measures to take care of the bowel, bladder, IV line. And this will be the right time for the patient, neurologist, to infiltrate the patient with the concept of rehab and introduce him to the rehab team. And in the subacute stage, where the patient may be in the rehab wards or in their homes, as in our country, individual assessment and doing a multidisciplinary team meeting, getting the goals fixed for each patient and working on it will be the next stage. And in the chronic stage, when the complications set in, and if there is some residual things which are on the patient, administering botulinum toxin for spasticity, and also moving towards an adaptive rehab in the form of appliances and assistance is something the neurologist will work along with the rehab team. Now, if this is all properly done, then the concept of a body function, activity, and participation will be evoked, and we'll be rightly hitting the sweet spot in the center. So this is the present scenario where the patient gets medical treatment by the consultant, but the patient gets individual inputs from each of the therapist, and finally they get discharged, but without any information of rehab, no realistic time-based goals, no individualized program, no quantifiable feedback, and no proper discharge advice on the rehabilitation. Thereby, there is no step-down care. So at the present, the community level, this is what is happening. Multiple individuals work on one patient, but there is no communication. However, the neuro rehabilitation is a process where the intention is to primarily place the patient in the society with the acceptable level of functioning. And this involves so many processes by so many people. So it is not something which can be done without a coordination. And the concept has moved on from simply terming the concept as physiotherapy, where in practice, a single person works on improving the muscle power, to the concept of rehabilitation, where the patient's priority and the goals come in front, and a lot of people work around the patient to get him back to his needs and his goals as soon as possible in a realistic manner. So when a team works around the patient's effort increases, and when he or she is included in the planning, the outcomes also increase. And this will be excellently done when the documented graph is shown, that the patient is improving on a graph scale from here to here, and they get motivated, and constant revisiting of the goals. And this is what the concept will look like when the consultant moves around the patient and everybody else reports to the consultant, and the single word of contact, the consultant talks to the patient and get the goals and initiate a rehab. This will be the multidisciplinary team meeting, where a process of brief rehabilitation will be set by the rehab team, and then the patient and the caregivers tell their expectations as how and when the patient should be, where they want the patient should be, and the rehab team displays their assessment and tell that this is how we are going to progress on a weekly or a monthly goals. And then this, if there's acceptable to the patient, and then a motion is set in, and then we review it, schedule a time, and meet every week and take things forward. Everything is done by a rehab coordinator. So perks of this kind of a management would be there won't be a micromanagement. There will be a different culture. There will be a constructive discussion. There will be a evidence-based medicine, and there will be a goal-oriented approach, and it will be a team approach rather than an individual player there. With such things, what we don't in our regular practice don't deal is, we give them the strength, we make them better, but proper information on the needs of the patient is not taken care. A financial need of the patient is never into the mind, and the employment needs of the patient is also on the roof, not taken care. And social interaction, home management is something, these are all the lacunae that happen in the rehabilitation in our country. And when an approach is in a way that we look at the patient as a holistic person, instead of just completing the treatment with the medical management, we look him as a holistic person, and the idea is to only put him back to the society. We are going to incorporate an excellent rehab zone where the patient is going to improve and get back to the society as soon as possible. Thank you for the opportunity. Thank you.
Thank you, doctors, for the presentations, which are quite reassuring. Like, we really need not be so afraid or scared, perhaps as long as we take care of the time factor. I would request our participants to start posting their questions. And meanwhile, I would like to ask you, the panelists, like, during our backroom discussions, you were mentioning that in the past 5 years, there has been a significant knowledge growth about strokes due to perhaps various awareness campaigns. But we still have a long way to go. So if you could any of you could just elaborate on those very specific and particular need zones, like where we are still lagging. Who would like to take that?
Yeah, I can take it. There are 2 to 3 hurdles that we face as a stroke ready center. First thing is, patients themselves are not aware that they are having the stroke. So what we try to do is to do as many patient awareness campaigns as possible to let them know that these are the symptoms of stroke. For example, they might have some weakness in the night. So they might feel that it is some low sugar. They'll have some sugar and they'll just sleep in the night, and by the morning when they wake up, they realize the limbs are completely paralyzed. So one section is more focus should be given to patient awareness campaigns. And unfortunately, second thing is, at the level of the doctors or the hospitals itself, a lot of hospitals are still not CT equipped, or the non-availability of neurologists in small peripheral centers, or as it's not as easy as diagnosing a heart attack, that you go with a chest pain, ECG machine is available in a smallest of hospital, in any smallest of corner you go in India, but at the same time CT is not available everywhere. So second part, the second hurdle comes in diagnosing. And third hurdle is, even you diagnose, you don't know that these therapies are available. So even second hurdle is to make doctors also aware that these new technologies or new advancements in treatments have come. And the third part of the hurdle we face is Obviously, cost is an issue in smaller centers like us. So we try to bring down the cost as much as possible where all the treatments are amenable to the patients. So we are trying to work on all these three parts, where first the patients are made aware of the symptoms, and when they recognize and go to the smaller center where doctors can immediately do a CT or an MRI, diagnose and do the first aid treatment, whatever they can do at their level. And if they find that there is something which they cannot do, like a large vessel occlusion, so we try to be in contact with them through telemedicine and ask them to refer the patient to us for further management. And the third part is we are trying to, as I was mentioning, to bring down the cost and make these treatments available to each and every strata of society.
So does this year's World Strokes Day have some particular message? Like, every year there's a theme or a message.
Yeah. This year's message is together we can be greater than stroke. So it's like everybody involved in stroke, right from the patients till the tertiary care doctors to hospitals, ambulance drivers, everybody play a part in this. So the theme of this year's World Stroke Day is together we can be greater than stroke.
Right. So
That was my last slide. So,
yeah, together we rise. I did see that. Yeah. So, Dr. Venkatraman, you mentioned about this incidence of stroke per 1 lakh of that's Indian population, right?
yeah, that's
So,
the closest we have as a data.
yeah. So, is it a worrisome factor? Has there been any rise in these incidents, say, over the past decade or 5 years? And if so, then why do you think it has been so?
The scientific data are not ripe enough to comment on that. If there is if you need to tell about the rise, you need to know the data before 5 years and now. So we don't have such a comparison. So it's only on the experience and the day-to-day activities we see is definitely rising. It's also the spectrum of stroke is now broadening. And by that, what I try to say is, initial days it was thought to be a disease of the elderly, only above 50 or 60. Most people are to be retired, and that also was one of the reasons why the patients never had a window to come to the hospitals early, because most of them will be retired at home and their children would be at work, and they wouldn't take the symptoms seriously and they won't report. Now the spectrum has increased, and now we see a lot of patients also in the younger age group, and a lot to do with the lifestyle. That's what it is easily said and easily taken, even though the data I don't have in my hand. It's a lot to do with the lifestyle. And we're in the urban center, as in Chennai, we see such a young stroke in about as early as 25 years till 40 years we are seeing it. And a lot to do with the change in the culture, the drinking habits, the late night sleeplessness, partying, and then the late night fast food culture. These are all playing a lot of role. And added to that is the immense pressure which they take on themselves in the work side, coping up for whatever targets they are. And those are things which we are absolutely seeing in front of us. We are seeing that.
Then there's another set, say 40 to 50 years, where you also mentioned that the reasons for strokes, they cluster up in that age group. So what changes after 40?
No, beyond 50, see, when we approach a stroke, there we see that the factors which lead to stroke are both modifiable and non-modifiable. What Dr. Fazal had posted were all those modifiable factors, where the cholesterol, diabetes, these are some things which you have on your control. But age as an independent factor is a non-modifiable cause for stroke, which that is why the age by themselves will lead to a stroke without any comorbidities also, which is very rare for us to see any person without any comorbidities after about 55 or 60 years. And now India has become the diabetic capital. So, but if you look back into this, where did this diabetes start from? Where did this hypertension start from? It is all because of the improper lifestyle that was invested in their teens, in their middle ages, where they went off the radar to make money or to support the family and gave less importance to their own lifestyle, leading on to a cumulative effect. And that hits you back at the beyond the 50 years of age.
And are children in any way a vulnerable group? Or does it have anything to do with age?
children, are you talking about strokes
Say
in
below 18 or, that other.
that's a very significantly lesser population, and that generally has something to do with genetics or some metabolic factors. That what we said, some not something that they are into fault, not something that they are into fault. There'll be something in their genes or something inside their body that provokes them. Even those patients who are less than 40, we make it a point that we investigate for such factors where intrinsically it acts like a aging factor to bring in the stroke risk. However, these stroke risks are manifested when the lifestyle goes in for a toss. But such things we don't see with children. If there is a stroke in a child, it's mostly a reason which is intrinsic, which is happening, which is creating a threshold for the stroke to be less, and we have to investigate and approaches as fast as possible to prevent further stroke.
Right. Dr. Fazal or Dr. Kavu, if you...
Just to add on to Dr.
Yeah,
Venkataraman's
yes.
point, so whenever there is a young stroke, we try to broaden the scope of investigations also. We don't do the routine investigations. Along with them, we try to do some other set of investigations to find out what the exact reason is. To say a famous case, there is like, Hailey Bieber, who is the wife of Justin Bieber, who had a mini stroke. So she had come out openly and talked about her experience. So she had a hole in the heart, something called a foramen ovale, which was diagnosed by the doctors in the US, and she had to undergo a corrective surgery for the correction of stroke and to prevent the further appearance of stroke. So we try to, whenever we have this kind of a younger stroke, we try to broaden the scope of investigations to find out what the exact cause of the stroke is.
Right. So, during the discussions, you also mentioned about how the spectrum of a stroke could be, say, from simple giddiness to complete paralysis. And at the same time, there could also be a lot of overlapping symptoms from various diseases. Like about this arm pain or unable to raise your arm, it's also for a heart attack. So how do we, explain it to a patient? Like, how can they be really alert to very specific symptoms of stroke?
So as we say, sometimes even it is tricky for the doctors to also find out. So for example, giddiness is a very common symptom that we encounter in the outpatient department, where at least we have 5 to 10 patients coming with the complaint of giddiness. So sometimes it is very, very tricky, or sometimes it is very trivial to say that it is stroke. But as we say, the BFAST symptoms, anything can be a stroke. So instead of neglecting or giving it time to get better by itself, I think a medical attention, at least a tertiary doctor who can say differentiate the symptoms from stroke, at least a medical attention would be better. Not at least not directly going to a neurologist, at least finding a good physician close nearby and just explain their symptoms to them and inquire whether they need any further attention or the consultation of a neurologist. But apart from BFAST symptoms, like we were saying, some balance or eye issues, even an eye disturbance can be a simple thing which can happen due to multiple reasons in the eye itself. So sometimes it is very, very tricky to say it is stroke. But at least, as I say, if at all you notice these symptoms, it is always better to take this to a doctor's attention, where he can guide whether these are stroke symptoms or this is due to something else.
Yeah, because like even Dr. Kavu, as you mentioned, they even say a low blood sugar could cause dizziness. So every time, and many times what happens is somebody's feeling dizzy, we rest for a while and we feel okay and we forget about it. But then should we really worry about every time we feel dizzy and rush to the hospital? Like, why is time so important to decide on this management, and what is the outcome? Dr. Kavu, if you would like to take that.
The patient who is diabetic for a long time, he's on the same medications, he's under control, or there is no recent changeover of medication. Suddenly he's feeling dizzy without missing his food. Sometimes we can get a clue of whether it is really due to low sugar or something pressing. It's mainly, we can rule out with the history, how he is before. So if it's always to be better to be a medical care rather than neglecting our symptoms. We don't want to get you into a bigger trouble. But if he is non-diabetic, taking medication, previously got hypoglycemic episodes, then he can try out with sugars or something. If he is not getting right, then he can at least approach a doctor who is very nearby. or at least get a clarification through a phone call.
If it's the first time, something has happened, it's better to be in the hospital rather than waiting. If the patient by himself knows that this is how, let's assume it was something due to his inner ear balance apparatus that is causing his giddiness. And for the first time, that shouldn't, even though the knowledge is right that an inner ear can cause this, there's no point in wasting the time in home. Let the doctors in the hospital decide whether that's an inner ear issue or a stroke. And then from there, anytime he gets the same symptoms, he may decide for himself whether he has this which was said by the doctors or is it something new. Because once you know the experience of that symptom, that okay, my doctor said this type of a giddiness is due to inner ear, but I don't have that kind of a symptom this time. I have something different. Just go to the hospital. But you get the same experience you would have been taught as to what to be done if it is not a stroke. That will be the simplest way to answer for all these less known or less thought of symptoms of stroke. If it's going to be a paralysis, anybody is going to rush to the hospital. That level of knowledge has now come into the society. But when these giddiness manifests as a stroke, it has always been a confusion with the patient's care. And that is something we shouldn't miss a time on and get to the hospital as fast as possible.
So Ishwar is asking.
One point to add, sorry for it. Just
Yeah,
to add
please.
one point, as you were saying, no, I think if at all somebody is diabetic, simply having a glucometer at home can just immediately reassure them or let them know that it is not due to low sugar. I think post-corona, everybody has a pulse oximeter where they can check the pulse rate or the oxygen level. And I think checking a BP, having a BP apparatus at home and glucometer are easiest things to have. To immediately, whenever a patient is coming to us with emergency, we see ABC, something called airway breathing and circulation. So I think immediate thing is to have just have a pinprick, a prick in the finger and check the glucose. If at all it is normal, I think they can immediately realize that it is not a low sugar and immediately go to the hospital. And unfortunately, one more thing is because the number one symptoms that brings patients to the hospital is pain. So if a patient is having a chest pain, number one, they have pain. Number two, they are scared that they might have a heart attack. And both these things are absent in a stroke. Number one, they will not have absolutely any pain. And number two, if at all you're not aware of the symptoms, you're not scared that it is a stroke. So you take it casually. So if at all you have these symptoms, immediately check a glucose at home. If at all you have a BP apparatus, which is easily available in every pharmacy now across the places, have a BP apparatus at home. Just with a press of the button, you know what the BP is. Just even pulse oximeters are also available everywhere. Just put a pulse oximeter to the finger, check your vitals. If you find anything abnormal, immediately rush to the hospital.
Yeah. So Ishwari is asking a related question. She says that, normally people panic when they hear the word stroke, and they also associate it to be with life-threatening. And so how can doctors assuage patients on this? And also there's an add-on question, whether the sunstroke also comes under the same spectrum.
I feel for this, let the people panic, because the panic only will bring them faster to the hospital. But if you become complacent and lazy, I think we are going to miss it. Yes, strokes can be definitely life-threatening if you miss the bus. That's for sure. But to be on the better side, we now all have all the medications, all the support system to create a atmosphere where not only the mortality is prevented, but also we could save as much of your function as possible. But a bit of thought into the stroke, that we have to rush to the hospital, otherwise this may end up with a permanent disability, or it may cause even a mortality, is something is realistic, and it should never be forgotten. And the basket of stroke, which Dr. Fazal had explained, is more to do with the vascular cause. It is more to do with the vessel wall occlusion, or a vessel wall leakage or bursting. That is not that will not bring in the heat stroke. And Fazal, if you'd like to add more.
Yeah, sunstroke is something completely different, and it is due to a complete other set of issues. So our stroke, what we are discussing with is either due to the clot in the brain or due to a hemorrhage or bleeding in the brain. And I think, yeah, the whole point of making people aware is to get medical attention, not panic. There are, as I was telling you, there are so many new advancements in medications or therapies. So doctors can only help if they seek medical attention. The whole purpose of these campaigns is to make them aware that these are the symptoms. And if at all you have these symptoms, no point of panicking. Just at least not going to the biggest of hospitals, at least get some medical attention where a doctor can check them and let them know that, okay, this is what is happening. I think this is what you need to do.
Right. So there are a couple of very relevant questions, like once a person suffers stroke and before he or she's reaches the hospital, you wait for an ambulance, or whether you should take the patient in an ambulance or you can put the patient in your own vehicle and just rush to the hospital, and what kind of first aid should be given at home before one goes to the hospital, or while on your way to hospital if you're taking the patient in your own vehicle and don't get an ambulance. So those kind of things, there are a couple of questions.
So when as Dr. Fazil said, if you could have a blood pressure or a pulse oximeter at your hand, and if it shows something very abnormal, those are not the patients whom you try to take in your hand, put it in your own vehicle and take to the hospital. And if you know that the patient is not speaking, not able to handle his oral secretions, these are people who may have a risk of aspiration on the way to the hospital. These are the only problems when it comes to transporting. However, if you think that the ambulance cannot reach your place at the right time, if it will take so long so that if waiting is of no point, I think in that scenario, whatever available modality is the best way to reach out to the hospital so that you make the best of it.
Devi is specifically asking that while she works out, her BP gets lower, and when she rests, it increases. She has had focal acute infarct in the left thalamocapsular region.
Yeah, so body's automatic response is whenever you are exercising or even you just go up a couple of flight of stairs, obviously your BP will go up. It is a natural response of the body. So that is not anything to be worried about. And second thing is she has had a stroke, and I think if at all she has consulted a neurologist, she would have been put under certain medications called blood thinners. And depending upon her age and certain set of investigations would have been done to find out what exactly is the reason for her stroke. And if at all she is not on medications or she has not consulted anybody, I think she has to consult. And if at all she is on medications, those medications have to be continued for the rest of her life to prevent further episodes of stroke.
Can cycling improve brain health or prevention from stroke?
Any form of cardio exercises, when done to the relevant age groups requirement, is going to be healthier for not only the body but also for the brain's health. It is not a direct way to come in that can cycling only prevent a stroke. It is not, but it is through its indirect effect on burning out the excess calories and also reducing the cholesterol accumulation, thereby leading to a less occlusion of the blood vessels. That also includes the heart, and thereby less reason for a worry for a stroke. That is how we can indirectly put it. But if, on the other hand, too much of an enthusiasm into the workouts that person is going to do is also not that great. Beyond, for example, if you're about 60 and you raise your heart beyond the rate where it is supposed to, that could lead to issues both to the heart and also to the brain. So workouts to the level that is being said or to be expected for the age is always healthier both for the body and for the brain. And for the previous person's thing, she has just put out a statement saying that I work, the BP gets lower. If it is due to the occupation, then the answer should be different, because I feel the person, if it's the occupation, she's getting engaged and her BP is not getting shot. And most cases, whenever the people are idle, they think a lot, and that increases the blood pressure in them. That would be a different way of thinking, seeing her, if the work is reducing her BP and rest increasing it.
So there's a question relating to nutrition also. Mr. Das wants to know deficiency of any nutrients in food for vegetarian or vegan people. Does that increase risk of stroke, and should they need do they need any supplements? Nutrition. How is nutrition related to stroke?
Vitamin B12 is something which is low in the vegetarians and the vegans, strictly vegans. And vitamin B12 has been known to be associated with a product called homocysteine. Now, this homocysteine is something which accumulates, when it gets accumulated in the blood, has a tendency to cause the fat layer accumulation inside the blood vessel wall. So in such cases, it would be always right to, if you are still following the diet that you want to follow, it will be better to take the vitamin B12 supplements, and this can in turn lead to reducing of the homocysteine. But this is not a regular day-on-day case. There have been ages that people have been in vegetarian diet, but if there is a mechanism through which a vegetarian diet can precipitate a stroke, it is through the rare mechanism of a B12 deficiency associated with the homocysteine elevation.
Mm. So I would like to bring in Dr. Kabul. This golden hour period was mentioned, that if a patient reaches within 4.5 hours, there is a probability that with treatment of medicinal treatment could put the patient in a safe zone. So the drug to dissolve clot in brain, is it 100% safe?
No drug is 100% safe, actually speaking. Even paracetamol we get for fever has its own complication. But this all depends upon the risk versus benefit ratio. So whichever is going to get you at the right benefit at the right time. So every drug has its own complications, but we depends on the situation we are using it. So now the stroke is most important, and the team is here to manage if some complication occurs. Every drug has its allergic reaction. So if some allergy happens, then we are there to manage it. This drug has a specific complication like bleeding in the brain or bleeding at somewhere site. So before injecting clotbuster, we are not injecting clotbuster to everyone who arrives at the proper golden hour also. We have certain indication, we have certain no to that drug. So we will check before injecting this drug. There are certain medical contraindication who are never to be injected this drug. So we'll check it, we will clear it. If the patient is clearly indicated, then we will give the medication. Even if some complication occur, we have to manage it. Now there can be bleeding in the brain. So for that, we will continuously monitor how he is in the ICU. And if there is something, we will take the CT and we will manage it accordingly.
So when a stroke patient is in the ICU and many times on a ventilator also perhaps, the relatives are also equally anxious and stressed out. So what is that they should be doing, or what is their role? How should they kind of, adjust to the new circumstance? What should they be knowing?
Yeah, actually, the general public, they are very much scared for ICU admission. The one thing is they are not frequently encountering the patient. They don't know how the patient is. For this purpose, we are there. We will frequently counsel them how the patient is doing, how his status is. And most of the patients think that the ventilator is the end of the life. It's not just like that. The ventilator is just going to support them at the right time so that the other organs get to its original position or near normal position to take care of themselves. So once they are able to handle their secretion, once they are able to maintain their breathing, we will take the tube off and we will make them into the rehabilitation phase. So we should never think that ventilator is the end of the life. It's just a supportive treatment. It's just for some days for some patient, some hours for some patient, and some weeks for some patient. But you can actively come out of the ventilator. So there should be positive hope that ventilator is not the end of the life. This is the message I want to put clear, because most of the patient thinks if you ask for some ventilator or put a tube in the windpipe, the people are so scared that they are going to lose that patient. It's not like that. It's just a supportive treatment. We have to give that at the right time so as to prevent complication and to prevent life.
Dr. Fazal, somebody wants to know, like, are there any diagnostic tools that help to assess whether the person is at risk of stroke, or in other words, maybe whether stroke can be prevented if there is an early assessment?
Absolutely, absolutely. There are a lot of screening, even like in our hospital, we have screening packages also where like yearly somebody is doing a health package. Similar ones, we do certain set of investigations to assess the risk of stroke. And for example, somebody is a diabetic or a hypertensive, or they've had a previous stroke, or they have a strong genetic or a family history of stroke. So generally we have certain set of investigation, or we have a questionnaire where if a patient is coming, like we take the questionnaire and it's like a checklist where we cross everything and we have a certain percentage of risk assessment, then we make them undergo few investigations. Like for example, there is a test called a carotid Doppler, where we scan, there is a connection blood vessel between the heart and the brain called the carotid, which sometimes where clots can be there, and these clots from here can dislodge it and go to the brain and cause a stroke. So with a simple scan, I can see if there are any clots here, and a simple echo for the heart, because heart can sometimes, most of the times, be a cause for the stroke, and a simple ECG to see if the rhythm of the heart is normal. So definitely there are few investigations to assess and screen patients for risk assessment if they can have a stroke anywhere in the future. And if we find anything alarming, we titrate the medication or optimize the medication, or and make them undergo few additional investigations to find out or probe further.
So is it possible also to kind of assess any average time span for recovery? Say a patient who comes within 4 hours, and then how long should he or she take the medicines for recovery? Or, as you said, physiotherapy has to start immediately. So then how much time period it is required, for a person to kind of come back to normal?
Actually, it depends from person to person, and a lot of things are involved. Whether a small vessel is involved or a large vessel is involved, or whether it is a hemorrhage or it is a clot, and how fast have they undergone a treatment, and what is the effect of the treatment on their body. So it depends from person to person, or not all fingers are the same. So we actually, as neurologists, whenever we are starting the treatment, we assess the patient at the end of 90 days. So that is what is our assessment. Till that, neurons keep on regenerating, something called neuroplasticity, where the neurons are trying to cope up and try to repair themselves. So our assessment is at the end of 90 days, and the recovery differs. From some patients become better within a week, for some people it will take a month, for some people it will take 2 months. So it differs from patients to patients, but the neuroplasticity or the repair of the neurons or the nerve cells keeps on happening till 90 days, or in some set of patients beyond 90 days also. So it's some, in certain set of patients where they have had massive strokes, it takes a bit longer for them to completely come back to normalcy.
So I'll just wind up with one more question to Dr. Venkataraman, like maybe at the cost of repetition, but could you just once again emphasize on those do's and don'ts at home for a stroke patient post hospitalization?
All right. So once the patient is back home, there are certain things. Let's talk what we don't need to do. Let's assume we have a very simple, straightforward stroke where the patient is paralyzed on one side and the upper limb is not moving. It will be a common practice for us to, if you want to lift the patient and make him sit up and give him a time to sit up, never try to pull the patient through his wrist or his hand, and that would be a dangerous point, because if the shoulder joint is the weakest joint of the body and it is supported by the muscles around the joint, and once the joint is not supported by the weakened muscles, if you're trying to pull him from the wrist, you're going to dislodge his shoulder joint, and this is going to cause a subluxation. Now, what will happen? There'll be an extreme pain in that limb, and that would result in the patient not cooperating for any rehabilitation on the limb. That will only postpone the time for rehabilitation. And as pointed out in the slide and as detailed by Fazil, it is the first 3 months or the 90 days or 12 weeks, whatever you want to call, is the time that we are aggressively looking at for the neurons to establish their connections with the surviving neurons, whatever neurons are there. And we don't want to waste this time with this simple issues that can be taken care. Always go around the patient and lift him from his shoulder and not from the hand. That is one thing that we'll have to be very clear. And when we know that the patient is not in a position to swallow things, at the least, don't attempt anything to be swallowed without the supervision of a proper swallow therapist or a nurse. And if at all something has to be tried, let it be under the supervision of a person. And there are too many things that needs to be done. But one thing which I commonly see is this shoulder subluxation, which the patients come up, and then because the patient would have been hoisted from his wrist, is that something need to be avoided, and that would be a simple message to you.
Right. So with those valuable inputs, I think we have to bring the curtains down on this episode of the webinar on management of stroke, continuity of care under the Hindu Wellness series and presented by Kauvery Hospital. Rise together and be fast are the messages we take back. So thank you all for joining, and especially our panelists for sparing so much time to explain the topic so nicely. Thank you once again.
Thank you.